floor is yours. I would like to thank the organizing committee. As you can see from the slide, disorder throughout the years, symptoms of the disorder show a change. But what about the disease load? There is no difference in terms of disease load. Treatment resistance in schizophrenia is a problematic definition due to the natural course of the disorder. Most of the patients show occupational or social decrease if the patients are followed out through the years. Is it similar to rheumatoid arthritis? The refractory nature of the patients perhaps might be explaining this. Treatment compliance is an important issue in treatment resistance, but in each case, is it the compliance causing the treatment resistance, or is there another factor? Treatment compliance, the most important predictors are side effects, disease severity, and the most important factor is the severity of the disease. This has not been published yet. It's very important to understand, is it the disorder showing resistance or is it the person showing the resistance? There is a study involving some European countries and Israel. Haloperidol was compared with atypical antipsychotics. Similar results were obtained, but when dropouts were added onto the analysis, atypicals were shown to be superior in comparison to haloperidol. I will skip through the definitions. There are various algorithms in the treatment of schizophrenia. This is EPAP's algorithm. Twice the patient is put onto a 4 to 6 weeks of atypical antipsychotic regime or classical antipsychotic. And after appropriate dose, appropriate timing, if your response is not adequate, you go on to the second drug. You, of course, analyze suicide risk and side effect profile. If you have 2 adequate attempts at treatment, if the patient is unresponsive, then you can go on to clozapine and go up to 900 milligrams per day. This is not binding, but these algorithms are very beneficial in helping us with our decision making. If the patient does not respond to clozapine, then augmentation protocols or supplemental treatments can be used. What about treatment-resistant schizophrenia? Plasma levels, treatment compliance need to be investigated. If these are within limits, then is it the fast metabolizing? Is it the problem with the antipsychotics? If there is no response to clozapine and there is no response to potent DA antagonist addition like sulpiride, amisulpride, haloperidol, risperidone, then ECT can be thought of. Psychosocial treatments can be thought of as well. What about treatment resistance? Randomized controlled studies and treatment resistance. Risperidone was compared to clozapine. The two were shown to be similar in effect. Fluphenazine and quetiapine were compared, similar effect. Clozapine comparative 1-year follow-up study showed that clozapine was superior. In a study about olanzapine, 3 studies conveyed clozapine to be superior to olanzapine, and 3 studies conveyed similar effect, similar efficacy to clozapine. As Professor Baybar said, Cochrane meta-analysis shows us that meta-analysis of 8 big studies, clozapine was shown to be superior. Long-term treatment, classical clozapine, long-term treatment, clozapine plus second-generation antipsychotics were shown to be better in improving cognition in comparison to typical antipsychotics. Another meta-analysis, second-generation antipsychotics were compared with clozapine. Clozapine in effect size was 2 times better during the follow-up period in comparison to the other second-generation antipsychotic. Although there are these data in the meta-analysis, there are other studies like McAvoy and colleagues studies where large series of patients have been studied. Unresponsive patients were involved. Clozapine arm showed significant improvement in PANSS scores. If the patient is unresponsive to an atypical, then going on to clozapine was suggested to be the better approach. Levitz and colleagues said if the patient is unresponsive to 2 or more atypical drugs, then clozapine might be the better choice. Meltzer had a study prevention study, 908 patients. Clozapine and olanzapine were compared in terms of suicidal behavior. The patients receiving clozapine showed less suicidal behavior. As a result, short-term studies and long-term follow-up studies, almost all of them showed that clozapine was superior to the other antipsychotics. Efficacy of clozapine shows itself in a long period, and it protects its effect over a long period of time. In a study by TANER, in a 2-year follow-up study, the improvement was present over the 2-year follow-up time. 350 nanogram per deciliter doses and higher doses were said to be more efficacious. Clozapine using patients, 30% of them do not respond adequately. These patients can be called as super-resistant patients or clozapine-resistant patients. Other than these meta-analyses, there are other techniques of less power. Adding an SSRI, adding benzodiazepine, adding an anticonvulsant, adding lithium, combination treatment, or ECT. Almost all of these drugs are possible to use with high doses as much as the patient can tolerate. We can go on to clozapine if the patient does not respond to these other drugs. When titrating the drug, fast track epilepsy might be a problem. Most of the patients do not tolerate these high doses. Augmentation strategies can be used. Again, positive symptoms. Persistent positive symptoms. High doses of drugs can be used. What about combination treatment and the advantages of combination treatment? Optimal receptor blockade need to be ensured. Side effects should be dealt with through combination treatments. What about the disadvantages of combination? Drug interactions might bring up negative results. More side effects can be observed. in side effect or lack of effect, it might be difficult to decide which drug to stop. What about combination treatments? Clozapine plus risperidone. There are many studies, but these studies are all small in size, even though they are all with placebo controls. Some of them have shown improvements, and some of them have shown, such as the study by Yağcıoğlu and colleagues, or another study by the same group with Professor Meltzer. It has been shown that risperidone plus clozapine, there is no significant improvement. Clozapine plus sulfuride combination results in 50% improvement in BPRS, and clozapine plus pemazide shows a decrease in PPRS. Low-dose clozapine can also be used within a combination regime, such as ziprasidone or amisulfuride combination. In depression and anxiety, scores improvement have been observed. What about low doses? I want to commemorate Esat, Professor Esat, when talking about low dose. Clozapine less than 100 milligrams. He had shared an anecdote that clozapine in low dose can be used in combination. In combination, olanzapine plus risperidone, olanzapine sulfuride, olanzapine sulfuride, olanzapine pimozide, olanzapine amisulfuride. Studies are present reporting positive results. What about lithium augmentation? It is thought that adding on lithium does not cause significant improvement in schizophrenia, but there might be schizoaffective patients, and some authors say that these schizoaffective patients might benefit from lithium adding on treatment. What about carbamazepine addition? Carbamazepine is said to be beneficial in some patients. Lamotrigine again, ECT again, have been reported in studies, but the results are not in line. What about alpha-nicotinic receptor partial agonistic substances? Results are various. 1H2 inhibitor fluvoxamine increases clozapine blood levels by 4 to 6%, but of course you can only use it by taking the risk into consideration. What about RTMS? RTMS results are said to be not certain. Partial responders and unresponsive patients to clozapine were added on to quetiapine and amisulfuride, respectively. Amisulfuride combination was found to be more effective. Again, in resistant cases, addition of modafinil was shown to be beneficial in certain negative symptoms without affecting SANS and BPRS, general psychopathology. Apart from these studies, what are the frontiers in this matter? Let's look at the receptors. Prefrontal cortex and schizophrenia, and hippocampus and NMDA is lacking in effect, lacking in activity. Subcortical D2 increases and alpha-7 is said to decrease. NMDA receptor, let's look at the NMDA receptor. Phencyclidine and ketamine are antagonists. Glycine, D-serine, and D-cycloserine can be used to reverse these effects, especially it can reverse the negative effects. Glutamatergic intervention. Glycine levels and clozapine response are said to be related. As you know, clozapine and glycine inhibit glycine transporter. N-methylglycine, sarcosine, glycine transporter inhibitor. When a glycine transporter inhibitor is used, such as sarcosine, at the gap, NMDA activity is increased. The studies conducted in this area, it was shown that sarcosine was shown to be more effective in comparison to D-serine on the negative effects. Total PANSS scores, it was shown to be non-effective. Clinical effects of sarcosine, SANS scores, cognitive scores, and total scores, significant effect has been shown. In conclusion, in schizophrenia treatment, new generation antipsychotics are more prominent as the first two options. Clozapine seems to be the third option. Clozapine can be used in patients who are unresponsive or who are not being able to use higher doses due to side effects. Clozapine can be used as an augmentation method. Augmentation and combination techniques should be designed over agents using different receptors and different neurotransmitters. In order to devise new treatment protocols, randomized controlled, large-scale studies are needed. Clozapine increases attention span. Smoking and hippocampal filter improvement is also observed with clozapine, and clozapine was shown to decrease cigarette smoking. Its effect on the alpha-7 receptors, alpha-7 nicotinic receptor, partial agonists, and NMDA receptors agonistic effect, or on the glycine transporter antagonists plus and antagonist drugs are, when combined with clozapine or with other antipsychotics, they are said to have a similar effect to clozapine. Perhaps this might be an area that needs further study in the future. Thank you.